today's topic is principles of management of premalignant and malignant lesions of the cervix and methods of screening. Cervical cancer is the most common gynecological cancer in our country. India contributes to 25% of the global burden. You remember from your anatomy classes, this is the cervix, which is also known as the neck of the womb. We visualize it with the help of a cusco speculum. It measures around 3 centimeters in length. You can see here between the internal and external os. This is what the cervix looks like. So, in the diagram here, this entire reddish zone inside is the endocervix. It is lined by single layer of columnar epithelial cells, whereas the pale zone which you find in the periphery, it's the ectocervix. It is lined by multi-layered squamous epithelium, which is pink in color. So, that is the stratified squamous epithelium. It has got 20 to 25 layers of cells. As the cell mature, they move from basal towards the superficial layer. This layer is the basal, this is the parabasal, intermediate and superficial cells. When we do a pap smear, generally the superficial cells tend to get exfoliated or shed, and those are the ones which are generally seen in the slide. A columnar epithelium is lined by a single layer, as you can see here. They are tall cells, basal nuclei, unlike the squamous cells which have got 20 to 25 layers. The columnar cells do not contain glycogen. Squamous cell layers, the basal layer and the superficial layer, the cytoplasm is replaced by glycogen. There is a lot of significance in this. Why I am saying this? Because if glycogen is there, then it stains with Lugol's iodine. Whereas if glycogen isn't there, like in columnar epithelium, iodine tends to stain negative. This is called the Squamocolumnar Junction. If you see the previous slide in here, this in the periphery between the beefy red and the pink red zone, that is the Squamocolumnar Junction. Or in this picture in here, this is the squamous epithelium, this is the columnar epithelium, this is the Squamocolumnar Junction. But the important thing to note is that the Squamocolumnar Junction does not remain stationary. It tends to move all through the life. For young girls, it may be in a particular location. With puberty, it may tend to pouch outwards. This is the Squamocolumnar Junction in this. Cervical neoplasias tend to start from the Squamocolumnar Junction or very close to it. This is a Squamocolumnar Junction. If there is any CIN or if there is cervical cancer, it will arise close to this zone. So, as I said, the Squamocolumnar Junction is located at the external os in young girls. But with menarche and during reproductive life, the cervix enlarges under the effect of estrogen. So, what we find is that the columnar cells, they tend to come towards the outside. The Squamocolumnar Junction migrates from inside more towards the outside. This is a phenomena which is known as ectopy. So, in the exams, questions may come, what is an ectopy or an erosion? It is just the replacement of the squamous cells by columnar cells. So, the columnar cells which are there in the endocervix move outward and the Squamocolumnar Junction moves outward. That is what is known as a simple ectopy or an erosion. What is ectropion? Ectropion is another condition. It's a normal physiological condition. Lot of experienced gynecologists also I have seen, they misinterpret these benign findings as something like a pre-cancer or a cancer. Squamocolumnar junction is this junction, is fully visible on the ectocervix, but sometimes under the effect of estrogen during pregnancy or on taking oral contraceptive pills, because of excessive estrogen exposure, this junction tends to move outwards. It pouts out like a fish mouth, okay, and that is called a ectropion. This process is called metaplasia. Transformation zone. Now, as I said, it tends to migrate upwards, outwards or inwards. So, what happens here? with menopause, what happens, this junction, it tends to move more towards the inside because estrogen levels is less. So what happens is that this was the original squamocolumnar junction, whereas the new squamocolumnar junction is this. That is because the squamous cells tend to form another layer on top of these columnar cells. This is called a phenomenon known as epidermidization, and when this happens, the squamocolumnar junction moves inside, whereas the original squamocolumnar junction can be represented by what are known as Nabothian cysts. Nabothian cysts happen because these columnar glands, their mouth tends to get blocked off by squamous cells, and the secretion tends to get accumulated within the cysts. So wherever we find Nabothian cysts, we know that is the original squamocolumnar junction, the distalmost place where the Nabothian cysts are there. And this is a new squamocolumnar junction. The area in between the original and the new squamocolumnar junction is known as the transformation zone. And whenever cervical precancer happens or cervical cancer happens, it happens in this transformation zone. When we do a colposcopy to try and identify these lesions, we have to visualize the entire transformation zone. So squamous metaplasia is a normal physiological finding. Lot of practitioners, they think that this is some sort of malignancy or some sort of atypical cells like dysplasia. They confuse dysplasia with metaplasia. Metaplasia isn't dysplasia. Dysplasia is when normal cells are replaced by abnormal cells, cells having atypical nuclei, atypical mitochondrial figures. Whereas metaplasia is a normal phenomena. One type of normal cells is getting replaced by another type. Squamous cells by columnar cells or columnar cells by squamous cells. As I said, these are Nabothian cysts. The original squamocolumnar junction was somewhere over here, whereas you can see this is the new squamocolumnar junction. The junction between the beefy red endocervix and the pale pink ectocervix. So the Nabothian cysts actually denote where the original squamocolumnar junction was. The area in between is the transformation zone. This is a new squamocolumnar junction. This is how it is denoted pictographically. It can move out or it can move in also. With age, it moves in, whereas in puberty and during pregnancy, it moves out. More the estrogen, that means more lactic acid accumulates, and then the squamocolumnar junction tends to move out. Ectropion and everything happens in a younger age, whereas if the lady is old, it tends to move in, and that is why we cannot sometimes see the entire transformation zone. It is then known as type 3 transformation zone. I will come to that. Okay. So with age, it tends to move inwards. With younger age, it tends to move outwards, particularly with pregnancy or with pills. But another thing is there, even in younger age, once the pregnancy gets over or the woman stops taking pills, what happens? Estrogen level again goes down. Then again it tends to move inwards. Okay. So estrogen more means the squamocolumnar junction will move outwards. The basic rule of the thumb. Now when it tends to move outwards, the initial part, for example in this slide, this area was originally having columnar cells. Now the squamous cells come in and forms a layer over that which is called squamous metaplasia. These new squamous cells is known as immature squamous metaplasia. Now either it can have two outcomes. Either the immature squamous metaplasia can become mature squamous cells with a lot of glycogen, and it is known as mature squamous metaplasia. Or human papillomavirus, high risk human papillomaviruses are there, low risk human papillomaviruses are there, or HPV virus, that can infect the immature squamous metaplasia and lead to dysplasia or atypical squamous epithelium, the starting point of cervical cancers. Human papillomavirus was discovered by Professor Harald zur Hausen. He got the Nobel Prize for this in 2008. There are a lot of types, more than 100 to 150 types of human papillomavirus. We need to know the 13 most important type which tend to cause the cervical cancers. And just because human papillomavirus infection happens, that doesn't mean that cancer will happen. 80 to 90% of human papillomavirus infections tend to subside on its own. The most important types are types 16 and 18. This is another question which might be asked. Okay. 99% of squamous cell cervical cancers are caused by human papillomavirus. Out of those, that 99%, 70% is caused by 16 and 18. And the commonest type is type 16. Can I have some silence, please? I'm putting in a lot of effort to make this presentation, and I would like attention. Last couple of benches. If you are not interested, you can leave the class. I'm not here to entertain all this nonsense. Yeah? So type 16 and type 18 and 31, 33, 35 are also very important. When we are talking about vaccines, we are looking at trying to prevent type 16 and type 18 infection. Only particular two types when we are looking at, then it's bivalent. When it's 6, 11, which are two low risk types, and 16 and 18, then it's quadrivalent vaccine. Human papillomavirus infection, 80 to 90% regress within 3 years. Sometimes it regresses between 8 to 9 months. If somebody asks you in the exam how many months it takes, it's normally 8 to 9 months. Only 5 to 15% persist, and less than 5% progress to CIN. So the median duration of new infection is 8 months. Only when the HPV high risk type infection persists do CIN or cervical precancers happen and cervical cancer happen. So integration of viral DNA, it leads to transformation of the cell. There are two particular genes in the human papillomavirus, E6 and E7, the ones you need to remember. They tend to downregulate the tumor suppressor genes P53 and retinoblastoma. Yeah. So E6 and E7, 6 is for P and 7 is for R. You can remember it alphabetically. What happens is that when tumor suppressor genes are suppressed, the abnormal cells, they tend to keep proliferating in the cell cycle, and that is the starting point of cancers. If tumor suppressor genes are properly working, then the abnormal cells won't proliferate. The cell cycle is stopped at that point, and that's a repair mechanism against cancer. E6 and E7 tends to inhibit the tumor suppressor genes, which is why the abnormal cells keep proliferating and it goes down that pathway. So that brings us to dysplasia. This is a classification which you might be asked. The earliest was the Papanicolaou classification. As you know, Papanicolaou was a Greek gynecologist, and Herbert Trott. Both of them went on to discover Pap smear. It's a very interesting history behind this. He was ridiculed widely by his colleagues, as often happens when he started taking the vaginal smears of the women he was seeing and treating. And then there was so much of a criticism. His wife came to his rescue, and Mrs. Papanicolaou is probably the lady who has undergone the maximum number of Pap smears in history. It is through her great self-sacrifice that Pap smear came into the existence. People came to know what is Pap smear, and it is the single most important discovery in gynecological cancers. It has prevented cervical cancers like anything. India is still suffering because even among doctors sometimes, the awareness of Pap smears is very less. You might see in the clinics, we are just doing examination, speculum and a vaginal examination. Pap smear is not getting taken. It is very, very important to take that. Pap smears there can be 5 classifications according to the Pap smear system. WHO has come with normal, mild, moderate and severe dysplasia. Bethesda system is what you need to remember. When we take a Pap smear and it comes back as normal, it is mentioned as NILM, negative for intraepithelial lesions or malignancy. Whereas if it is abnormal, if it is a low degree of abnormality, then it is known as ascus. Atypical squamous cells are where probably the nucleoli just starts increasing. The nucleus tends to be just slightly bigger, 2.5 times as compared to a normal squamous cell nucleus. And the nucleus by cytoplasm ratio starts increasing. With more abnormality, it becomes low-grade squamous intraepithelial lesion. With higher abnormality, where the nucleus probably occupies the entire cell, no cytoplasm remaining, it's called HSIL. So that's the highest grade. And when we tend to biopsy these lesions, then the abnormality is described as CIN, or cervical intraepithelial neoplasia. This is a term which was coined by Regan. Okay. So CIN, if we see these slides, The abnormal cells are particularly in the basal area. You can see there is a lot of nuclear crowding, large nuclei which are seen. Whereas the topmost cells, they look normal, lot of cytoplasm, normal nucleus. So the abnormal cells are only the lower 1/3. So that's the CIN1. When it's affecting till the middle 1/3, it's CIN2. Whereas if it's affecting the entire epidermis, okay, from low to till high, you can see the abnormal cells on top also having enlarged nucleoli. So that's the CIN3, which is the immediate precursor of cervical cancers. This is another important slide you might be asked in the exams. CIN1 is the lowest degree of abnormality. So 60% of the lesions tend to regress to normal squamous cells. Only 30% persists, 10% progresses further to CIN3, and 1% tends to go on to become cancer. Whereas if it is CIN3 or carcinoma in situ, then as compared to CIN1, only 30% regresses, whereas the majority tends to persist, 56%. And you can see that 12% tends to progress to cancer. So that's a huge difference, and that is where interpretation, first taking the pap smear. If the pap smear is abnormal, then we tend to biopsy the lesion, and therefore these biopsies need to be interpreted by pathologists who are trained gynae pathologists or gynae oncopathologists. They make a lot of difference. If somebody says it's a CIN1 where it is actually a CIN3, it makes a huge difference. CIN1 maybe there may not be much of a bother, we can just follow up. Whereas CIN3, we need to excise the entire transformation zone. As a summary, more than 80% of CIN1, I would say, regresses by 10 years. About 10% of CIN1 progresses to CIN3. 20% of CIN2 progresses to CIN3. Less than 5% of CIN1 progresses to invasive cancer. Less than 10% of CIN2 progresses to invasive cancer. 50% of CIN3 progresses to invasive cancer. But this progression is a slow process. Cervical cancer happens slowly over 15 to 20 years. It has got a huge period of latency, and that is why we should have a robust screening program in our country. In UK, when I was training there, we hardly got any patients of cervical cancer. Radical hysterectomy used to happen very less. Whereas in India, we find that women are coming in stage 3. That is because the screening program isn't robust. Half of the people have not heard of what is human papillomavirus vaccine. CIN3, you can see the cells, abnormal cells through the entire width of the epidermis. So that's the true precursor of cervical cancer. The WHO has come up with these goals. This is another important question, to try and eliminate cervical cancer. Eliminate is different from eradicate. Eradicate means no cases. Eliminate means we are trying to reduce the incidence less than 4 in 1 lakh women. Out of 1 lakh women, less than 4 women will have cervical cancer. It's built on 3 pillars. Primary prevention, vaccines. 90% of girls should get vaccinated with HPV by the age of 15 years. Secondary prevention, that is screening. 70% of women need to be screened with a high performance test by the age of 35 and 45 years. It's important to say that in the state of West Bengal, the screening is less than 1%, and we are trying to achieve a target of 70%. That is how grave the condition is. And of the women who tend to get diagnosed with cervical cancer, 90% of them should receive treatment for precancers or cancers. India has got a huge global burden. As you can see, out of the incidence of more than 5 lakh patients with cervical cancer worldwide, India has 1,22,000. And India also contributes to 1 in every 4 patients who die of cervical cancer. Now coming to the vaccines. Your friends, your neighbors might be asking this. They don't see whether you're a senior doctor, whether you're a junior doctor. They might just come up to you in a social gathering and say, I've been hearing about these vaccines. What do you tell about it? So there are 2 types of vaccines which used to exist earlier. One is Cervarix, which is against HPV 16 and 18. It is bivalent. As we know, 16 and 18 contribute to 70% of cervical cancers. Whereas Gardasil is the one which is marketed by GSK. It's the most widely prevalent vaccine. It provides protection against 6, 11, 16 and 18. It's important to note that these are inactivated or killed vaccines. These are not live vaccines. Alright. So they use what are known as virus-like particles. So these virus-like particles are not the virus themselves, but there we tend to remove the these virus-like particles. They have antigenicity. That means it can provoke the antibodies which will protect against the virus, but they do not have infectivity. India has been producing its own quadrivalent vaccine now, which is known as Cervavac by Serum Institute, the same Serum Institute which produced the COVID vaccines. When we are talking about Gardasil, between 9 to 14 years, or Cervarix, between 9 to 14 years, 2 doses are sufficient at 0 and at 6 months. More than that, if somebody asks you, you say that the protection is provided for 15 to 26 years as well. Bivalent Cervarix, then 0, 1 and 6 months. If it's quadrivalent, Gardasil or Cervavac, you tend to give 3 doses, 0, 2 and 6 months. The span between the second and third dose is 4 months. Yeah? It is getting included. Actually, the cost is where the government is negotiating with the concerned parties involved. Lot of states have included them in their vaccination schedule, like Punjab, Sikkim, okay. And central government is, Nirmala Sitharaman actually told in last budget presentation that she is going to implement it. It's high time that India does so, because Bangladesh already have it, Nepal has it, yeah. And Australia is also vaccinating them males, not only females but males. So Federation of Obstetrics Gynaecology Society of India, we are actively saying that women need to get vaccinated, whether it's in the schedule or not. Okay. 9 to 26 years, there is the maximum protection, 80%. Protection lasts for around 8 years. All right. But the important thing is that you need to say, even after vaccination, screening is important. Just if somebody has vaccination does not mean that screening needs to be stopped. Both vaccines and screening will prevent 70% of the cancers. So this is the FOGSI guidelines, all right. 9 to 45 years is the licensed age of use. Preferred target group is 9 to 14 years, 2 doses. 15 to 26 also has got great benefit, 3 doses. 26 to 45, you say there is still benefit, that the benefit probably is only 40 to 50%, because by that time HPV infection would have already taken place. So 15 to 26 years, you are giving 3 doses, 0, 2 and 6 if it is Gardasil or Cervavac. Older age group also 3 doses. For HIV positive or immunocompromised girls, it's the same recommendation of 3 doses. Alright. Now coming to the secondary prevention or screening. What are the different methods of cervical cancer screening? One is pap smears, which used to exist. We have got conventional or liquid based cytology pap smears. We have visual inspection under acetic acid. We have visual inspection again under Lugol iodine. So these are the screening tests. Colposcopy also may be included in the screening test, but not a first line screening test. Only when a lady tests positive for, say, a pap smear is coming back as abnormal, or if it's acetic acid dense white, VIA aceto white, or Lugol iodine, we find a bright yellow abnormal lesion, or if none of these tests are negative, but clinically, if you're looking at the cervix and it looks abnormal, then we go for colposcopy. With colposcopy, if we identify the abnormal lesion, then we tend to biopsy it as well. So if somebody asks you about between all the screening tests, which one will you prefer? The one which you prefer is the HPV screening test. That is the screening test of choice, primary HPV testing. Why? HPV testing has got a sensitivity and a specificity of 92 and 98% of detecting CIN lesions. Okay. Whereas pap smears, while it is widely prevalent, even in our OPD we have only pap smears, the sensitivity of picking up is only 52%. The specificity is good, 96%. So if a pap smear says it's negative, then probably there is a 96% chance that the lesion is actually negative, there is no lesion. Whereas if the pap smear is saying positive, then we have a doubt. Okay, so that is important. Specificity is high, but the sensitivity is poor. It does not pick up positive lesions as such. So that is where, if the choice is there of the HPV test of screening, primary HPV test needs to be done. Or we can do both pap smear or primary HPV testing, which is known as co-testing. In resource poor settings, sometimes we train the healthcare workers, or we doctors ourselves do it. We put the speculum and we add 3 to 5% of glacial acetic acid and we check the cervix. What age group do we screen? If we are using HPV testing, the target age group is 25 to 65 years. Whereas if we are using VIA, visual inspection under acetic acid, the age group is 30 to 65 years. At what intervals? If we are doing HPV testing, every 5 years is sufficient. If we are doing cytology, every 3 years. Whether it's cytology or whether it's HPV testing, we need to start at the age group of 25 years, okay? And we stop at the age group of 65 years, provided 3 consecutive testing tends to come back as negative, alright? Cytology is every 3 years, okay? And HPV or co-testing is every 5 years. HPV, again I am mentioning, we start at the age of 30 years. Cytology or pap smear, we start at the age of 25 years. Suppose if after the screening somebody comes back as CIN 1+ or positive even on biopsy, for how long we need to follow up? We need to follow up for 20 years. Screening following abnormal reports is 20 years, okay? And follow-up method is also by HPV testing or cytology. We tend to do it every 12 months. So these are some pictorial diagrams of how we test. We put a speculum like this. This is a wooden spatula, which is known as a air spatula, correct. Sometimes generally this edge tends to sample the endocervix, whereas this one tends to sample the ectocervix. We have a cytobrush also like this, which is placed within the endocervix. It helps in endocervical sampling. Sometimes when we have glandular abnormalities, then this test is important. After testing, we stain it on we tend to use a slide to brush it on, and then this is fixed in 95% alcohol. Pap smear, it is the advantage is that it's widely used. Training mechanisms and for quality control assurance are well established, but the sensitivity, as I said, is poor, only 52%. This is where HPV testing is more important. HPV testing, the sensitivity is 96%. And it needs a very good cytopathologist, very good lab technician to stain the slides properly so that the abnormal cells are seen. And it has got a very high rate of inadequate reports, because suppose if when you are taking a sample there is blood or there is pus like discharge, then it will come back, report will come back as negative or inadequate. That is where liquid based cytology helps. We again use a brush like this. After taking the sample, we rotate it some 3 to 4 times. We break off this tip and we put it within this. What helps? This helps is that inadequate reports are less as compared to conventional cytology. And this liquid we can actually centrifuge. From the sedimented part, the slides are prepared. From the supernatant liquid, we can test it for HPV testing. So HPV testing, when we say, it is basically collecting it like liquid based cytology. When somebody tells you how we are doing a HPV testing, this is how we do it. Rotate it some 3 to 5 times, okay. So slides are easier to read, less number of inadequate smears. Samples can be used for HPV testing, and training and mechanisms for quality control are well established. These are the advantages. Disadvantages, same as for conventional cytology. Both are known as pap smears, alright. I'll just I have one more picture of a slide. I will show it later. Most HPV infections, therefore, as I said, 80 to 90% are transitory. They tend to subside on their own. Most CIN1 therefore regress 60 to 70% as I showed in the slide earlier. CIN2 and 3 are the true precursors because they regress only 60, maybe 30%, 40%, and therefore they can progress more. And we should treat CIN2 and 3. Then we come to visual inspection under acetic acid. So what is the principle behind that? See, normal cells, the nucleus is smaller in size and the protein content within them is also less, which is why on giving acetic acid, it tends to, there is very little protein to coagulate. So therefore, there is hardly any effect on normal epithelium. Whereas, if we are using acetic acid, the acetic acid tends to coagulate the protein content. Larger nucleus, more protein. With more abnormality, the protein content tends to increase. And therefore, it tends to stain dense acetovite. Dense acetovite means the lesion is abnormal. If they ask you how much percentage of acetic acid, it's 3 to 5%. 3% is used for colposcopy. Colposcopy we can also use for checking vulval pre-invasive lesions or VIN. In that case, we tend to use 5% acetic acid. So the range is 3 to 5%. This is how we prepare it. 5 ml of glacial acetic acid with 95 ml of distilled water. Somebody may ask you, suppose you are examining the cervix, you have not yet applied acetic acid. You find white lesions already present. What can they be? They can be a condition known as leukoplakia. Leukoplakia by itself is not malignant or premalignant, but it may hide areas of abnormality. Whereas there can be also genital warts which are caused by HPV 6 and 11, low risk. So the quadrivalent vaccine also protects against these warts. This is a typical picture of a cervical polyp. Whereas you have heard about trichomoniasis infection, it can look like a strawberry-like appearance in trichomoniasis. Now when you are giving acetic acid, it can be low-grade abnormality or high-grade abnormality. Low-grade abnormality will stain very less, okay, just faint whitish with geographical borders. Whereas if it is a high-grade abnormality, then it will stain dense acetovite with sharp borders and elevated surface. This is what a cancer looks like. Chalky white with acetic acid application, it has got a raised margin. It will bleed on touch. Okay, it's almost like a ulcerar proliferative lesion, like a cauliflower. This is what a cancer looks like. It's even more florid looking as compared to CIN3, ulcerative growth. VILI, which is visual inspection under Lugol iodine. Now this test is also known as the Schiller's test, where we use 5% Lugol iodine to stain the cervix. So acetic acid, you have to remember, it tends to coagulate the protein. More the protein content with abnormal cells, the whiter the lesion becomes. Whereas Lugol iodine, what it does is that Lugol iodine, you remember I told that squamous cells, they contain glycogen, so they tend to stain glycogen, and when glycogen gets stained, the color turns mahogany brown. So mahogany brown means normal, okay. Whereas if columnar epithelium is there, see this is columnar epithelium, okay, it does not contain glycogen, so it stains yellow. This yellow is not abnormal. Whereas if the squamous cells they stain yellow, then we have to seriously think that something is there. That's because the abnormal cells, they do not contain, abnormal squamous cells, they do not contain glycogen. This is how it is prepared. 10 grams of potassium iodide in 100 ml of distilled water and 5 grams of iodine. This is a typical appearance of VILI negative. So if somebody says somebody is Lugol iodine negative, that means it's a normal report. Okay, it stains mahogany brown, lot of glycogen in the normal cells. Whereas if it is starting to stain, this is also a normal picture actually. This is the normal columnar epithelium. Normal columnar epithelium will stain yellow. And this is the, as I showed in the trichomoniasis, there can be a strawberry-like appearance, or when you are using iodine, it is a leopard skin-like appearance. Now this is what a VIN positive looks like. These are squamous cells, alright, but it is not staining mahogany brown. It's starting to stain pale yellow with geographical borders. You remember the slide with VIA positive, but it was a low-grade lesion? This is like that. It is yellow, but it is not dense yellow. Okay. So this is a low abnormality, probably a CIN1. Whereas if it is dense yellow like this, okay, it is known as mustard yellow or canary yellow. Then it is probably a high-grade lesion. We need to excise this entire transformation zone. Either we can take a biopsy initially, know what it is, CIN1, 2 or 3, and then we can do treatment, or we can do it in the same setting. So conclusion, normal squamous epithelium stains with Lugol's iodine, it becomes mahogany brown and is VILI negative. Low grade lesions have pale yellow color, high grade lesions bright yellow, canary or mustard yellow. And VILI can be falsely positive in metaplasia, infection and postmenopausal cervix. Next is colposcope, discovered by Hans Hilselman. It has got a magnification of 4 to 16 times. The picture looks similar to VIA, but with magnified images, you know that you are looking with more detail. It can be minor abnormalities like very thin acetowhiteness with geographical borders and fine mosaic pattern. Mosaic pattern happens when there is abnormality. But if it's a coarse mosaic pattern or a dense acetowhiteness, sharp borders like this, then it's a higher grade of lesion. It's a coarse mosaic pattern, inner border sign, ridge sign. Okay. This is what a malignant lesion looks like. Raised margins, lot of coarse punctations you can see here, dense acetowhiteness, abnormal vessels. Okay. There are some comma-shaped corkscrew vessels, and you can see that it's an ulcer and it bleeds on touch. We use something known as a sweet score. If the score is more than 5, then we tend to go ahead on colposcopy and tend to do the treatment. Different types of transformation zone is there. This you all don't need to know in that much detail. When there are abnormal features, it appears oyster-like acetowhite. So if the lesion turns white very fast, it keeps on staying white. Once you apply the acetic acid, you have to wait for 1 minute. Because as I said, the normal columnar epithelium also may appear white, but the whiteness fades. Whereas if the whiteness tends to persist after 1 minute, then it's an abnormal lesion. And it's dense acetowhite, it has got raised margins, then it's a high-grade lesion. So you can either screen and treat in a single visit. In our country, women hardly come to show all this. There is a lot of social stigma, there is a lot of fear. So when you first see the lady, it's better if you identify the lesion, treat her in the same setting. In all likelihood, like in our setting, the lady may not come back for follow-up. In developed countries, what happens is that suppose they see a lesion like I showed you, acetowhite lesion, they first take a small biopsy. And the small biopsy comes back as CIN 2 and 3. Then in a separate sitting, they tend to either ablate or excise the entire transformation zone. Because there the compliance is much higher. So the compliance is much higher in developed countries, whereas in developing countries it's less. So that's why we need to do it in same setting. So all high grade CIN need to be treated. Low grade CIN we can review after 1 year. Low grade means CIN 1. High grade means CIN 2 and 3. So when we treat, we have to ensure entire transformation zone is treated. The minimum depth of treatment should be 7 millimeters because that's the depth up till which the crypts are there. Treatment can be of two types. This is another question. It can be ablative or excision. Ablative treatment is not first choice. Ablative treatment can be cryotherapy, like cold therapy, or it can be electrocoagulation, or cold coagulation and laser ablation. Excision, we tend to use LEAP or loop excision of the loop electrosurgical excision procedure. It is also known as large loop excision of transformation zone or LEDS, or we can do a laser excision, or we can do a cold life excision. Ablative treatment, there is a strict criteria. We should be able to see the entire transformation zone. Lesion should involve less than 3 quadrants of the transformation zone. Entirely located in the ectocervix. If the abnormality is extending into the endocervix, or if we find there is no evidence of invasive cancer, if we look like it looks like a big ulcerative cauliflower-like lesion, then we should not do ablative treatment. We have to excise the lesion. If there is no history of pregnancy, then we can do no history of menstrual bleeding. If it's just a simple looking lesion which is occupying less than 3/4 of the cervix, completely in the ectocervix, only then we should do the ablative treatment. Ablative treatment can be by cold or it can be by heat. If we are using cold, it's a cryotherapy. We use liquid nitrous oxide -89. With both cryotherapy as well as thermocoagulation, there can be a persistent watery discharge for 3 to 4 weeks. We have to, and there can be sometimes vaginal burns, rarely PID, cervical stenosis. Cure rates are 90 to 95% probably if you select the patients properly. Excision treatment is loop electrosurgical excision procedure. How you do it is like this. There is a cervix, you tend to remove a cone like this, alright. So if the lesion is very small lesion, type 1 lesion, then it's a shallower cone. Whereas if the lesion is extending inwards, it's a more deep cone, 12 to 15 millimeters. Type 3 means the lesion is extending too much into the endocervix. So you have to make a more deeper cone. So LEEP, when do you do? When there are larger lesions. As I said, with ablation, when it's occupying less than 75% of the ectocervix. More than 75% means you have to do a LEEP. Lesions in type 2 and type 3 transformation zone. Type 2 and type 3 transformation zone, but depth of involvement of endocervical canal should not exceed this. And with a high suspicion of microinvasive cancer. Ideally, if possible, all patients we should do LEEP. But with LEEP, it's an excision procedure. What happens is that in future pregnancy, there can be cervical incompetence. The cervix tends to become short and there can be spontaneous miscarriage in the second trimester. That's why often for younger women who actually fulfill the criteria of just the ectocervical lesion, less than 75% lesion, okay, and not invasion, we tend to do thermal ablation because that maintains the cervical length. When do we do, so these are the indications for LEEP or LEDs, okay, CIN 2 and 3 we have to do a LEEP. CIN 1 which is persistent for more than 2 years, this can be a question. When do you do ablation for, initially we do ablation for CIN 1, but more than 2 years if it is persisting, we do a excision. Excision means LEEP. Cervical glandular intraepithelial lesions, we tend to do a LEEP or a LEDs. Americans use the terminology LEDs, British use LEEP, okay, otherwise it's more or less one and the same. If VIA is positive or if it's VILI positive, then all we need to do LEEP or LEDs. This is how it looks like. Once you excise the lesion like this, you make a single pass like this. It looks like a crater. The lesion has been excised, okay. You tend to take this out and send it for histopathology. So as I said, follow up. Once it's CIN 2 or 3, we tend to follow up for 20 years. And what is the modality of follow-up? We can follow up with HPV testing itself every 12 months. Okay. Thank you. The rest of the time we can give out to any questions. And in the next class, next Monday, I'll be talking about cervical cancers. So far I have talked about cervical precancers and the prevention, vaccines and everything. So what are the different methods of screening? Pap smear. Pap smear. Okay. What is the commonest method of screening? Mostly which is used? Pap smear. Pap smear, what are the two types? Conventional and liquid based. Okay. What is the best method of screening? HPV testing. Okay. What is the primary prevention modality to prevent cervical cancer? Vaccines. What are the two types of vaccines? Gardasil, which is the one which is most commonly used? Gardasil. Okay, the quadrivalent type. But India, which is the Indian vaccine? Sarvavac. That is also quadrivalent. Which are the serotypes which cause cervical cancer mostly? 16 and 18. Which is the commonest type? 16. Okay. What are the two genes which are the E6 and E7? Good. Okay. If any of you want these presentations, it can be saved in the desktop. So what are the two lesions, differential diagnosis? You are seeing the cervix, it's already looking white. And genital warts. Okay. Genital warts are caused by which serotypes of HPV? 6 and 11. Okay. Suppose if somebody has genital warts, how will you treat? I have not put that in the slide. Okay. Imiquimod is used. It's an immunomodulator. Imiquimod you can use for 8 to 16 weeks. Okay. Or you can use trichloroacetic acid. If somebody is coming with genital warts in pregnancy, you can use trichloroacetic acid. Or you can just ablate the warts. Or you can excise the warts. Okay. Will you give somebody HPV vaccine if they already have the warts? No, because the infection is already taken place and the natural course of infection. But what can you suggest that lady as a matter of prevention of cervical cancer? For screening, pap smear will anyways take place, okay, whether the infection is there or not. Only vaccines cannot be given if the infection is already there. A lady comes and asks you, I have HPV infection. I am very afraid I will have cervical cancer. How will you counsel? What will you reassure? What is the percentage that subsides? 80 to 90%. Within how many months it subsides? 8 to 9 months. Okay. What is the percentage which persists? 5 to 15. Less than 5% becomes cancer. Okay. What is the percent? What is Schiller's test? Yes, Lugol iodine 5% we are using to stain. Okay. The iodine which we use in OT tables, that is not Lugol iodine, but that is povidone iodine. That has got a different concentration. Whereas Lugol iodine is particularly 5% iodine and it is prepared in this way. Okay, I showed you in that slide. What is the age group for screening? Age group for screening? 25 to 65 is for which age group? For which modality of screening? 25 to 65? For pap smear and HPV testing. When somebody asks you about screening, first talk about HPV testing. Okay, pap smear is widespread, but HPV testing should be done. Whereas for VIA, the age group is 30 to 65 years. What is the interval for pap smear? Every 3 years. Pap smear is every 3 years. Okay. HPV testing, wherever HPV is there, it's every 5 years. Co-testing stands for pap smear plus HPV. That's why it's also every 5 years. Whereas VIA starts at 30 years and every 5 years. This is limited resource setting, but ideally if we have facilities, we should follow this. Okay. Lady at the age of 25 comes to you for vaccines. What will you say? We can give, yes. How many doses we can give? Yes. And you can say you can go for either quadrivalent or bivalent. If quadrivalent, there are 2 options. Okay. Somebody who is HIV positive, how many doses will you give? She is 14 years of age and she is HIV positive. She wants to know, No. Even for 9 to 14 years, but HIV positive, 3 doses. Immunocompromised, we go for 3 doses, irrespective of age. Okay. Attendance targets. CIN3, what percent progresses to cancer? 50%. And actually 50% is for carcinoma in situ. Okay. CIN3, it's almost like 10 to 12%. CIN1, it's 1 or less than 1%. Okay. It has been wrongly written CIS here. It should be CIN3. CIS is just slightly more aggressive. It is 50%. Whereas it regresses in this ratio. Okay. CIN1 regresses 60%, CIN2 regresses 40%, CIN3 regresses only 30%.